That's a really proper question these days, where we have a lot of new treatment coming for these patients. Of course, historically, we have divided the patients' goals based on the risk of thrombosis and kind of used the low risk or high risk patients to define which patients need some approach. For low risk patients, we only use aspirin and eliminate the cardiovascular risk. For high risk patients, historically, we've been doing hydroxyurea as the oldest chemotherapy that's been around for 40 years. We were doing pegylated interferon or a standard short-acting interferon. That's been actually in PV for 30 plus years right now, but the biggest fear has been discontinuation and toxicity tolerance. We kind of are moving in a better thing that way now with the novel interferon called Ropeginterferon that has a better tolerability and also more patient convenience, where it's given only once every 2 or once even every 4 weeks. So patients definitely appreciate it. In a refractory setting, we have Ruxolitinib or the JAK inhibitor, really tremendous agents for symptom and spleen control, where we have really mature data from the past. And we have novel agents that come into the era. For example, very innovative hepcidin mimetic called PTG300 or Rusfertide that currently entered phase 3 clinical trial. We have some other novel agents that we are looking forward to explore, but unfortunately, somehow a little bit of a pushback because the toxicity in these agents is the most important, like the HDAC inhibitors or MDM2 inhibitors have not moved on beyond the current development because of concerns for gastrointestinal tolerance. That's actually very important in a disease such as Polycythemia Vera, where patients have more benign disease, so they live long. So even a low risk, a low grade toxicity is very important. So we're gonna look whether that's gonna find a place, but currently we have good frontline options where we prioritize or use hydroxyurea mostly, and it is still the most commonly used agent. However, I think the interferon are gonna be used more in the frontline setting, especially in patients who are young, or for example, is the best agent for pregnant females. Because it's not teratogenic. Now with approval of Ropeginterferon, which happened in November 2021 in US for patients with Polycythemia Vera with no designation. So it could be used in frontline, it could be used in a secondary agent, and I think they're gonna move more into the questions, what are our goals of therapy? Whether we are only satisfied with the control of thrombosis, or we're gonna move forward and look into goals of survival and disease progression. That's currently the biggest deal that we're gonna be looking at.